Welcome to this new session about asthma. In this session, we will cover some objective like asthma symptoms and classifications, triggers and non-pharmacological treatment, pharmacological treatment and patient education points that we need to address to our patient to improve their asthma medication and compliance. What are the main symptoms of asthma? Asthma have main symptoms of shortness of breath. The patient have difficulty breathing. Coughing usually happen with asthma. Wheezing, where there is a sound in the chest of a wheeze. And chest tightness. Also, there is decreased forced expiratory volume, which is the amount of air that the patient can expel in 1 second due to restriction of airflow. Why most of asthma patients fail on treatment? This is because of two reasons. First one is underutilization of anti-inflammatory therapy, which is steroid. Usually patients with asthma need a preventer or a long-term control, which is the steroid inhaler, and should be used regularly to prevent the symptoms and the attacks. But what happens in reality, the patient will not comply with using the preventer regularly. And overuse of short-acting beta-agonists like Ventolin, which is used only in case of like exacerbation or severe symptoms. And most patients will rely mainly on Ventolin to relieve symptoms, and they misunderstand how to use it, and they can use it like as a preventer. So the patient can overuse the rescue therapy, which is Ventolin, or underuse the anti-inflammatory, the steroid. And this is what happened in asthma patient. This is a normal airway on the left, normal lumen, wide lumen, and no inflammatory cells. When the patient go into the asthmatic pathway, we can see there is mucus formation in the lumen. The lumen can be narrow, so the breathing can be difficult. We can see also infiltration of inflammatory cells like eosinophils or leukotrienes, and these play a major role in the inflammation and chest pain in asthma patients. Regarding classification of severity, asthma can be classified into two main groups, which is intermittent and persistent. Intermittent means that it can come and go, but persistent means the symptoms are regularly happen with the patient. We can divide them according to the impairment in lung function and the risk of exacerbation, which is attack of asthma. And regarding the impairment, the symptoms we can be gauged according to the symptoms: nighttime awakening, how many nights the patient can wake due to symptoms, or the use of short-acting beta-agonist or interference with activity. So in intermittent, the symptoms happen like less than 2 days per week, and consequently the use of SABA will be also less than 2 times per week because it's related to the symptoms. And nighttime awakening, the patient will not wake up at night due to symptoms, and there is no interference with activity. Regarding exacerbation, the patient will have like 0 to 1 attack per year. In persistent, the risk of exacerbation happens when the patient have 2 or more attacks per year, so he is classified as persistent. Persistent can be subclassified into mild, moderate, and severe according to also the symptom: nighttime awakening, use of SABA, and impairment of activity. So the symptoms and use of SABA, if the patient have symptoms more than 2 days per week but not daily, can be classified as mild. Moderate when he have symptoms daily, severe when he have symptoms throughout the day. The same happen with the use of SABA. If he use SABA more than 2 times per week, more than 2 times per day but not daily, he is mild. If he is used daily, it's moderate. Or he uses SABA several times per day, he is a severe persistent asthma. In nighttime awakening, if the patient wake up like 1 to 2 times per month, he is mild persistent. 3 to 4 times per month moderate, and more than once per week he can be classified as severe. Regarding impairment in activity, minor and moderate or extreme limitation can be classified as moderate and mild, moderate, and severe. What are the asthma triggers? So usually asthma is variable. That means that the patient may have symptoms for a specific time or a specific season of the year, but he can be okay in other times. So there is triggers which increase the incidence of asthma. You must be aware of these triggers to inform the patient and he can avoid as possible. These triggers include cold air, dust mites, stress, medicine like NSAIDs like ibuprofen or diclofenac. It can increase decrease leukotriene, and can increase also the asthma symptoms. Exercise, of course, exercise increase the effort and decrease the lung capacity, so can exacerbate also asthma. And there is one type of asthma which is exercise induced asthma, where only patient having shortness of breath during exercise, and this can be relieved by only using SABA before the exercise. Pollen, and this is why asthma is common in the spring or autumn due to the spread of pollens. Smoking, of course, pets. Infections like viral infection, usually after viral infection, asthmatic patient will have exacerbation or severe worsening of asthma. Pollution, molds, and some foods that cause allergy. So in asthma, usually patient will need to use two types of medication, the reliever and the preventer. The reliever will relieve symptoms by allowing smooth muscle relaxation in the bronchi, allowing the patient to breathe easy during attack. And the preventer would be a steroid, which decreases the inflammation in the airway and prevent further attack. So ICS, which is inhaled corticosteroid, have a big role in asthma, and they have a lot of beneficial effect and at the same time adverse effects. So what are the beneficial effects that inhaled steroid can produce? They decrease eosinophil numbers, mast cell numbers, T lymphocyte or cytokine production. This is due to the fact that they suppress immunity, so they decrease all these inflammatory cells or mediators. They inhibit transcription of inflammatory genes in the airway epithelium. Also, they reduce the endothelial cell leak and upgrade the beta-2 receptors. They have a lot of side effects and should be aware of this side effect to inform the patient if he experience is normal from the steroid, and if it's severe, he need to consult the doctor to modify the treatment. This include hoarseness, dysphonia, which is difficult talking, oral thrush because they decrease the immunity in the mouth, allow the overgrowth of candida, so it will cause thrush. So for patients with asthma who are using steroid, it's very important to counsel them to wash their mouth after using the inhaler. Growth retardation and skeletal muscle myopathy, osteoporosis and fracture, all these are side effects commonly with steroid, and it can happen with inhaled steroid like systemic also. Cataract and glaucoma, adrenal axis suppression, because overuse of steroid for a long time will suppress the normal production of cortisol from the body. Immunosuppression, of course, because steroid decrease immunity and decrease all the inflammatory cells. Impaired wound healing and easy bruising, hyperglycemia and hypokalemia, hypertension because they cause sodium and water retention, psychiatric disturbance. All these need to be aware and need to educate the patient about who are using long-term inhaled corticosteroid. What are the non-pharmacological management of asthma? What are the tools we can provide to patient to advise to reduce the symptoms and the exacerbation? A lot of things can be done, like weight management. We need to ask patient to achieve a normal BMI of 18.5 to 25 kg per meter square. Avoid triggers, of course. Patient need to keep a diary of the asthma symptoms. So which season of the year he has the symptoms and what type of food usually happen with it, the level of symptoms, and is it related to exercise. And the patient need to usually avoid these triggers. So we need to keep a diary and avoid all the triggers that is related to him. Increase physical activity. So patient need to do some physical activity like brisk walking at least 30 minutes per day, most days of the week. Stop smoking, and it's very important and the most important factor to reduce the asthma. Carry quick relief inhaler for patient of asthma. Usually we mention that it is variable disease, so patient can have the attack anytime, so it's important to keep an inhaler with him all the time. Review the inhaler technique. So we need to inform patient about correct inhaler technique, because the inhalers are versatile and a lot of companies producing many devices. Patient may be confused about using the inhaler, maybe wrong use of inhaler will not provide any benefit to patients. So it's important to review this inhaler technique with the patient and ask them to teach back and tell you how he is using the inhaler, and you can guide him to the correct procedure for using the inhaler. Monitor of peak flow. This is a peak flow, expiratory peak flow monitoring. This can be done with a device at home, and the patient can record the best reading for himself to monitor his lung function. What are the pharmacological management of asthma? As we mentioned, it mainly depends on using relievers and preventer. Reliever usually produce smooth muscle relaxation in the bronchi, allowing easy breathing and relieving shortness of breath. The first group is bronchodilators. This can be classified into short-acting beta-2 agonist or long-acting beta-2 agonist, like salbutamol, or another name is albuterol or levalbuterol. The LABA, which is long-acting, is exemplified by formoterol and indacaterol. The common side effect of this medication, usually they are sympathomimetic, so they produce QT prolongation, tachycardia, hypokalemia, and nervousness. And there is a black box warning or contraindication for their use in case of using LABA, may increasing the risk of death in asthma patient when used without inhaled steroids. So if a patient is asthmatic, he is using LABA, LABA must be combined with steroid, otherwise he have an increased risk of death, like using seretide, which is salmeterol fluticasone, which is salmeterol is LABA plus fluticasone, the ICS. But salmeterol alone cannot be used in asthma. It have a high risk of death in this type of patients. Pregnancy category is C, which means that it depends on the risk benefit and decision of the physician. This type of medication usually produce bronchodilation by relaxing smooth muscle in the bronchi, allowing bronchodilation. Second type of bronchodilators would be the anticholinergics, like ipratropium and tiotropium. Ipratropium is Atrovent and tiotropium is Spiriva. So the common side effects are like related to anticholinergic side effect. like pharyngitis, xerostomia, constipation, or sinusitis or bronchospasm. Should be avoided if patient has hypersensitivity to atropine because they are atropine derivatives. And pregnancy category, ipratropium is very safe and considered as B, while tiotropium is a class C. Bronchodilators like inhaled mast cell stabilizer like cromolyn, and this is now little used right now. And the most common side effect is sore throat and bad taste in the mouth. And hypersensitivity to cromolyn is a contraindication for use. And the beneficial effect of Intal, which is cromolyn, is usually that it is safe in pregnant. Methylxanthine under bronchodilators also, which is thiophelin, is a very common medication to be used, but currently it's have a little use or limited use due to side effect and toxicity from overuse. And as you know, thiophelin is a non-therapeutic index drug, means the patient can fall into toxic level very easy with many interactions and a lot of toxicity happening. So many safe alternatives are used now. So it's only used if in the case the patient is not responding to the regular treatment, which is SABA or anticholinergics. And the common side effects like tachyarrhythmia, atrial fibrillation, nausea and vomiting, insomnia, tremor, and irritability. And this can further into convulsion and death if the level is very high. The black box warning and contraindication, that is hypersensitivity to thiophelin, and category C based on risk-benefit ratio of the medication. The inhaled corticosteroid, which is preventers, they need to be used regularly to control the symptoms, prevent attacks, decrease the eosinophil count, leukotrienes, they decrease also the cytokines, so it have a beneficial effect for controlling asthma on long term, so they should be used regularly. And one of the pitfalls of patient using these inhalers that they usually do not use it regularly, so our role is to force them to and inform them about the beneficial effect of using steroid, because the fear of people from the word steroid, but actually it is inhaled, it's have minimal absorption to the systemic circulation, and it have a very beneficial effect on the lung and the airways. Like examples, beclomethasone, budesonide, cyclosonide, fluticasone, and mometazone. The side effects are, as we mentioned, oral thrush, where the patient will have oral candidiasis because they depress the immunity in the mouth, they kill the bacteria and increase overgrowth of candida, so patient will have like oral candidiasis, so patient need to rinse his mouth after using. And secondary hypocortisolism due to high doses, as we mentioned, adrenal insufficiency, pharyngitis, and upper respiratory tract infection. Pregnancy category, budesonide is the safest because it is classified as B, while C can be classified for other steroids. Leukotriene modifiers, like there are two groups, leukotriene receptor antagonist, which is montelukast and zafirlukast, and lipooxygenase inhibitor like xilutone. The most commonly used is Singulair, which is montelukast. So it is leukotriene receptor antagonist. As you know, leukotriene play an important role in asthma. If you block these receptors where leukotriene work, so you will get a benefit from reducing asthma attack. So it is a preventer in nature. So it is usually used to prevent asthma. And the common side effects are upper respiratory tract infection, and the very important side effect, which is neuropsychiatric changes and behavior and mood, hepatic dysfunction, and usually happen with elevated liver function tests. It's category B, so it can be used in pregnancy. Chewable tablet should be avoided with phenylketonuria because it contains phenylketonuria product. Monoclonal antibodies, this new type of medication, is biological medication. This medication work on interleukin. So interleukins have a role in asthma. So blocking this interleukin with antibody like mepolizumab, omalizumab, which is Xolair, or risiluzumab, which is administered in an office or a clinic. So this can be like last resort when the asthma symptoms are severe, not controlled with conventional treatment, with steroid, with normal inhaler and Ventolin. So the patient can try a monoclonal antibody, and this can be used regularly. Like omalizumab need to be used every month, and like an injection should be given subcutaneously at home, or the patient can prefer to take it in the doctor office. The side effect that these products decrease body immunity, so the side effect is related to immune related, like increased viral infection or upper respiratory tract infection, because they depress immunity. As long as they are injection, the patient may have injection site pain and bruising. Urticaria and anaphylaxis can happen, and this can happen with any injection. Contraindication, pregnancy and omalizumab, and hypersensitivity to the drug, and the pregnancy category depend on the product, each product from this list. And all this we are talking about asthma, which is like normal asthma, but there is acute asthma, and acute asthma happen when there is deterioration in symptoms over hours and days, increase in breathlessness, wheezing and coughing and tightness, difficult talking a sentence, tachycardia, tachypnea, reduced peak expiratory flow rate, and reduced oxygen saturation. So in these cases, the patient may need admission to hospital for treatment of acute asthma, and can be classified into moderate acute asthma, where the patient have normal speech, normal oxygen saturation, and treatment based on using prednisolone oral, like 40 mg daily for 5 days, or salbutamol up to 10 puffs, like in using an inhaler. This can be managed at home or in a doctor office. Severe acute asthma, where the patient cannot speak in full sentence. In this case, the patient needs oxygen, so can be done in the doctor office or in a hospital. He needs prednisolone oral or IV hydrocortisone. He can use salbutamol 5 mg, but it's better to be given through nebulizer. Life-threatening acute asthma, and in this case, the patient have silent chest, cyanosed, arrhythmia, hypotension, altered consciousness, and this need to be admitted to hospital. Patient will need initially to be given oxygen, salbutamol via nebulizer, and steroid IV like hydrocortisone. Ipratropium 0.5 mg nebule can be added. So this is different from chronic asthma, which is acute asthma, which is happened due to exacerbation of symptoms. And what about device types in asthma? The most common is PMDI, pressurized metered dose inhaler, like salbutamol inhaler or seretide evohaler. This type of device come in a canister and a mouthpiece, and it needs coordination that the patient need to press the canister and inhale in the same time. So usually for adult, if the patient need to use PMDI, they need a spacer device where this device can be linked to the mouthpiece, and the parent can press the canister and give the child the time to inhale from the spacer. Second type is soft mist, like Spiriva Respimat. This type do not produce like a mist, like an air mixed with like some mist, and usually twisting the base of the device, then pressing the blue button will release the medication. And the third type, main type, is dry powder inhalers, and it comes in many devices like Turbohaler in Symbicort, AccuHaler like Seretide AccuHaler, Ellipta and Relvar and Discus and Seretide. And in all these medication available as powder, and there is a technique used by the device to release the powder, so allow the patient to inhale the medication. You need to see the instruction on each bottle how to release the powder. In Seretide, in Seretide, actually the Discus one, you need to slide the top circle, then push the lever down, then inhale from the mouthpiece and rinse the mouth after use. For Turbohaler like Symbicort, as in this picture, you need to twist the bottom and inhale only. So many devices with many procedures, so it's important for us to know how to use every device so that we can deliver the message to patient to allow them comply with their medication to take the proper benefit from these medicines. What about the education points you need to give to asthma patient? You need to education patient about the basic fact about asthma. You need to explain the difference between asthma and normal airways. As we mentioned, there is a narrowing in the airway, infiltration of cells. So you need to explain it in a simple way to the patient. You need to describe what happened to the airway when asthma attack happened. The role of medication, as we mentioned, you need to educate how the medication work. And also, as we mentioned many times in this lecture, the difference between controller and preventer, and stress on using the quick relief inhaler during symptoms and the regular use of preventer, and ask the patient to teach back to confirm his understanding. You need to use some skills. You need to ask patient to demonstrate the use of review of nebulizer. You need to know how to use a nebulizer if the patient is having a nebulizer at home, so you need to explain to him how to use the nebulizer. Assess ability to recognize and monitor symptoms, and discuss the goal of medication. You need to explain why he is using this medication. So as long as the patient is informed about the benefit of the medicine, he will comply to it and you will get a better benefit. Environmental control measures, like educate on how to identify and avoid triggers. So as we mentioned, you need to inform the patient about the asthma triggers, how to avoid these triggers, and the most important one is tobacco smoke. And for here we come to the end, and I thank you and I hope you learned something new, and we can see you in another session. Goodbye.